We're very pleased now to have with us the Chief Medical Officer of KidsPeace, Dr. Matthew Koval. He is board certified in child and adolescent psychiatry and has served as a practitioner and a medical school professional in the field, professor in the field for many years. In his current role, he directs the medical activities related to the services provided across the KidsPeace organization. Dr. Koval, welcome to the podcast.
Thank you. It's great to be here.
It's great to have you. Let's get started right off the bat. In your opinion, what's the biggest source of the negative stigma surrounding mental health treatment?
Well, I would guess it's really just the lack of understanding. When you're dealing with mental illness as opposed to sort of a physical illness, there's sort of nebulous things that people can't really put their finger on, right? So, for example, if you have a strep throat, you know that your throat is sore, a doctor's going to put a swab in your throat, they're going to see bacteria in there, they're going to put you on an antibiotic, and it's very sort of cut and dry, ABCD, this is what's going to happen. Whereas with mental illness or emotional or behavioral problems, it's not, there certainly isn't a bacteria or a virus that causes those things. And it's usually multifactorial, right? It could be a person's support system. It could be a stressor in their life. It could be a tragedy. It could be the loss of a loved one. It could be work. It could be partly their own genetics because depression runs in their family.
And isn't it the case, too, that there's behaviors and that a layman wouldn't necessarily associate with a mental health condition, and I don't know why I'm irritable, and then
right.
Well, it's because you might
right.
be clinically depressed,
right? Or insomnia, for example. Gee, I just can't sleep. When they might think it's because of their bed or their pillow or whatever, their sheets, when really it's because they've been suffering with depression or anxiety. So I think it's really this issue of having a fuller understanding of what's going on with folks when they have mental illness, and because it's something that's more difficult to understand and wrap your head around, then I think this idea comes up that, well, then it's something you should have been able to handle on your own. For example, gee, if you just had a stiff upper lip, or if you were a better person, somehow these things wouldn't happen to you. And really what we know now and what we've learned over the years is that's simply not the case. Again, I alluded earlier to genetics. I mean, we know now that depression runs in families, anxiety runs in families. If you had a parent who was depressed, you're twice as likely as the general population to have depression in your lifetime. If both of your parents were clinically depressed, you're 4 times more likely to have depression in your lifetime.
Wow. That's just a sort of a shocking kind of thing that you would not necessarily know. And of course, if you're talking about stigma, the other generations may have actually had even more of an impetus not to get diagnosed, not to seek treatment.
Yes.
You wouldn't know until you went back and said, oh, boy, now I realize this may be a real contributor. I didn't realize it when I was growing up or right now, but now that I know what's going on with my own head, wow, that's where that was. Now, okay, so stigma is a barrier to people seeking help. What are some of the clinical ramifications of this reluctance to get help? What does it mean in terms of the success of treatment for these conditions?
Well, the very main thing off the bat is that the person simply won't get help at all. So they'll continue to struggle in silence, or they'll continue to attribute their sleep problems to their bed or their pillow rather than what might really be going on underneath, or marital problems or problems with your son or daughter. All those kinds of issues you attribute to something else. And so the main thing is that people don't seek treatment. So it's been estimated that, like in a normal primary care office where many people go to just get their regular health care needs, that 1 in 3 of those folks have a diagnosable mental illness. Could be something like mild anxiety, or it could be something far more severe. But out of those 1 in 3, only about half of those get the treatment that they need. Part of that is because of the stigma. They don't want to go and get that treatment. Part of it is, to be honest, that sometimes the primary care docs are too busy kind of stamping out other fires, the high blood pressure, the diabetes, et cetera, that they're not attuned to those issues to even be able to make that referral.
And it becomes an issue where you're like, what else could they have done? They're in front of a medical professional, preferably or probably one that they trust, and they're not bringing this up, or the professional isn't bringing it up. But what is that? That has a lot to say, I think, for people in their minds of thinking about, do I really want to seek this kind of treatment?
Right. I would say to the primary care folks out there that they should really be mindful of what we call the doorknob comment. And some people aren't familiar with what that is, but what that means is the doc's at the door, the appointment's finished, and then the patient says, hey, I wanted to say one more thing, because they've been waiting the whole time and trying to get up their courage to say that this one other issue. And a lot of times, unfortunately, the doctors are busy, and they might be like, well, we'll get you next time, and they're out the door. But if the docs would pay attention, they might hear that person say, I've really been having trouble sleeping, or I've been so anxious at work, I can't even think straight, or I'm having so much problems with my wife or my husband. And those are the things really the doc should stay at the door and really should listen to, because they may get a wealth of information.
I think probably everybody has a story in their lives where they're like, that happened to me in various things. Now, does the stigma issue, the impact of it, does that have an impact once treatment is underway? Do you still see a reluctance? What's been your experience?
I think that can still happen, but for the most part, it's really the provider and me as a psychiatrist. It's my role, and one of the first things I want to do is establish a rapport with that client, right? I want them to know that they're in a safe place, that they can talk about the issues that are really bothering them, that I'm not going to judge them, that I'm not going to make snap judgments about their life or their lifestyle. And when you establish that rapport, then I think you start to see that reluctance and that resistance kind of melt away. And I think that's, again, the impetus of that is on the provider, right? Because the person's coming in with their preconceived notions. What our job is to say, your preconceived notions really aren't what this is all about. What this is about is you and I joining together to try to come to a resolution to the things that are bothering you.
A level of trust.
Exactly.
Okay, now I understand. As you just said, you won't be judging me. You won't be saying, oh, there's something, this person is not a good person. Together you can find a way to address these issues. And that's really I would say that's kind of the definition of the beneficial relationship you should have with your medical professional.
Right. I don't know how many times I've had an experience where I've sat with folks who are talking about something tragic or very painful in their lives. And we're sort of taught, and I'll say especially as men, but even women and other folks and children will have an experience where, gee, I can't cry, I can't show my emotion. That's not what I should do. And it's really remarkable when you say to somebody, it really feels like that. It seems to me like that really makes you want to cry, or that's really so painful for you. And you're sort of giving them permission to have those feelings. Mm-hmm. And what I found is once you've given them the permission, the person realizes it's a safe place. Again, I'm not going to judge you. And maybe some tears flow, or maybe other emotions come out. And invariably, the person will say to me afterwards, I'm so glad that we had that discussion. I'm so glad you didn't just stop where we were, or push a tissue box in front of me and kind of be like, dry it up. But you're saying it's okay. That's what we're here for. We're here to examine those emotions and try to figure out what we can learn from them.
Again, one of those experiences I think everybody's had in their thing.
Or with a family member or friend, you've had those experiences.
Absolutely, where it's you're there to listen. You're there to give them permission to feel that and to express it.
Exactly.
Now, we were talking before we went on about, one of the issues that we face in this field is a shortage of practitioners, psychiatrists, therapists, mental health workers. And I was wondering if there was an impact of stigma on that. But you're saying not really.
Yeah, I think it probably was there in the past. And I remember when I was in medical school and I started getting the idea that psychiatry was kind of the right fit for me. And I would tell friends or family members, and they would say, well, Matt, you'd be better as a real doctor. And I was like, well, I think I am going to be a real doctor. So there was that issue. But I really think that has changed a lot. I mean, and I've worked in academic medicine for a long time before I joined KidsPeace. And I think what we're seeing is students who find themselves interested in that area, or resident doctors, they are much more willing to go into that area. And they've also been able to garner the respect of their colleagues, because as psychiatry has become more of a science, just like other areas of medicine where we do have definitive medications and causes and treatments and evidence-based treatments, that has brought us more into the fold.
Mm-hmm. Mm-hmm. Dr. Matthew Koval serves as Chief Medical Officer for the KidsPeace organization. Thank you for joining us today. It's always a pleasure. We hope you come back.
I will.
Okay. I'm Bob Martin. Thanks for joining us as well, and we hope that you join us again for more conversations with KidsPeace. Take care.